Hello. In this episode we discuss glaucoma. Remember, the acute angle closure glaucoma is a differential diagnosis of acute eye symptoms, including acute eye pain or redness or visual impairment, usually associated with pain and headache, while open angle glaucoma or chronic glaucoma is a painless visual loss. And based on this, we will discuss their risk factors, pathophysiology, and management in a contrast and comparative way. What is the pathophysiology of acute angle closure glaucoma? Remember, decreased drainage in the anterior chamber, which means decreased overall flow of the aqueous humor, would result in buildup of aqueous humor in the posterior chamber, and that would result in reduction of the iridocorneal angle. Now, understanding of it requires having a clear idea of how the aqueous humor moves. So imagine this middle finger of me is the iris, and this is the cornea, and this at the base of iris is the ciliary body. This is anterior, this is posterior. Anything anterior to the iris is the anterior chamber. We can think of it as a chamber between iris and cornea, and anything posterior to the iris is posterior chamber. My fist shows the location of the lens, for example, and that's in the posterior chamber. Now, aqueous humor is produced in the ciliary body in the posterior chamber and then moves from the posterior chamber to the anterior chamber, and at the base of this anterior chamber, where we have the angle between the iris and cornea, the so-called iridocorneal angle, we have the trabecular meshwork with the canal of Schlemm that drains this through the uveoscleral drainage as well. Now, there could be some short-acting triggers or risk factors that temporarily, in an acute manner in terms of timing, block this drainage and therefore cause acute buildup of pressure in the posterior chamber because it cannot move and drain, and this would press the iris, and as you can see, the iridocorneal angle would close further, so it's becoming a vicious circle of further closure and further pressure buildup to a point that pressure could build up in the posterior chamber to a point that may press on the optic area, on the retina and optic disc, and cause blindness. The second arm of understanding of pathophysiology requires our understanding of the adrenoreceptors and muscarinic receptors involved in the whole process of production and drainage. Remember, alpha-1 causes pupillary dilation, and M3 muscarinic activation causes activation of the sphincter pupilla and pupillary constriction. Then we have beta-2 and alpha-2 adrenoreceptors involved in the production. Beta-2 stimulates production, and alpha-2, that is a regulatory receptor in the sympathetic nervous system, decreases the central sympathetic discharge and therefore reduces beta-2. And then we have carbonic anhydrase that's involved in the process of production. And then we have prostaglandins that facilitate the uveoscleral drainage. This is all you need to know about the pharmacotherapy that we will also discuss. Now, talking about acute angle closure glaucoma, we have these short-acting players and risk factors and triggers. So first, risk factors. What are the risk factors? We talk about older patients with positive family history. The demographics favors Asians, and underlying etiology could be hyperopia or farsightedness. A couple other lens and anterior chamber pathologies such as lens dislocation or anterior uveitis are also predisposing factors. How about the triggers? Well, based on the discussion of the receptors, any condition that causes pupillary dilation would result in further buildup of tissue in the iridocorneal angle. So either sympathomimetics with alpha-1 activity or anticholinergics. Sympathomimetics could also mean prolonged stress. And also a very famous case presentation is a patient who has spent a long time in a dark room, such as a movie theater. What is the case presentation? We have a sudden onset eye pain with red eye, headache, nausea, and vomiting, and possible blurred vision. What are the physical exam findings? Hard eye with fixed dilated pupil. Please build a habit of touching the eye of the normal condition as opposed to that of glaucoma, and if you just touch it once, you would see what does it mean to touch a hard, almost rock solid texture of the glaucoma. What's the first test? Regardless of the type of glaucoma, the very first test is Schunz or ocular tonometry. What is the intraocular pressure that reaches the emergency levels? That's an intraocular pressure greater than 50 millimeter mercury. What's the best test? The best test differs in acute versus chronic glaucoma. For acute angle closure glaucoma, the best test is gonioscopy. We need to measure the iridocorneal angle. What's the management? Always remember, if an ophthalmologist is available within an hour, the best management is emergent referral, even though you may still try initiating the treatment in office or emergency room. However, there are some possible conditions in which you may consider elective referral and initiate the treatment in the office. What are those conditions? If the patient is otherwise stable and asymptomatic, if the intraocular pressure is less than 40 millimeter mercury, and of course if there is no ophthalmologist available within an hour, we need to initiate the treatment. Now, what is the focus of the treatment in acute angle closure glaucoma? The focus of the treatment is any maneuver that can manipulate the pupillary size and iris dynamics. In other words, we need to use short-term management options with immediate response. So what is the target? Either avoiding pupillar dilation by use of intraocular or eye drop beta blockers such as topical timolol, betoxolol, or use of muscarinic M3 agonists such as pilocarpine, or use of alpha-2 adrenoreceptor agonists such as apraclonidine, because they also reduce beta discharge. They block the beta-2 discharge. Next line in the management is focusing on either reducing the production or increasing the outflow, and so for that we can use IV mannitol or carbonic anhydrase inhibitors. So again, remember, for the acute angle closure glaucoma, the first line of treatment is manipulation of pupillary size, and then we focus on getting rid of excess production or use IV mannitol. What are the supportive management in parallel that patients would need? Pain management with opiate and management of nausea and vomiting. Now, here is an important point. Should we use scopolamine for the management of nausea or vomiting? No, because it's an anti-muscarinic agent, so we need to use ondansetron, the serotonergic compound, for the management of nausea and vomiting in acute glaucoma. What patients require surgical management? You don't need to memorize any indications, because all patients, even with one episode of diagnosis of acute angle closure glaucoma, require laser iridotomy as a prophylactic procedure. If this does not work, which is our first line surgical management, long-term management, then we consider iridectomy. The difference is in iridotomy, they just dig a hole in the corner of the iris to improve the flow, while in iridectomy, they take a tiny piece of the iris with the same final result. Now, let's turn our attention a bit to compare open angle glaucoma. What are the risk factors? Here, the patients are not necessarily elderly. We are just having the risk after age 35 to 40. Demographically, we are not dealing with Asians, but African Americans and South Central Americans have high risk. Regarding the underlying eye disorders, the patients with nearsightedness or myopia have the risk of open angle glaucoma. Also remember that another long-term risk factor such as diabetes could play a role, as opposed to the short-term risk factors and triggers we had in acute angle closure glaucoma. Now, what's the pathophysiology? Here again, the disorder has a more prolonged structural abnormality, and that is structural abnormalities in the trabecular meshwork, which results in decreased drainage, but a more gradual increased intraocular pressure. Now, what is the case presentation in which you need to be suspicious of this chronic open-angle glaucoma? You could have a patient older than age 35 who either requires frequent glass or lens change or complains of difficulty adapting to dark environments. What are the first and best and other evaluation and tests needed in this open-angle glaucoma? Again, the first test is going to be tonometry, but confirmatory tests are ophthalmoscopic exam showing cupping as well as visual field testing showing loss of peripheral vision. Now, what is cupping? Cupping means increased cup to disc ratio. What is the cup? It's the central whiter area or brighter area of the optic disc head. If you take a look at the ophthalmoscopic evaluation of the retina, you would see that there are two circles concentrically, the outer circle and the inner circle. Now, what's the increased cup to disc ratio? It means if it is greater than 0.3 or 30%. That's the inner brighter central circle occupies more than 30% of the diameter. What are the management options? Here, the focus of the management is first, improved outflow of the aqueous humor, and second, decreased production, and third, receptor acting pharmacotherapies that we discussed. So what's the first line of treatment? Use of some prostaglandin analogs to facilitate the uveoscleral outflow. What's the alternative first line management? Laser trabeculoplasty. Again, remember, in the case of acute angle closure glaucoma, the procedure was iridotomy or iridectomy, but here, because the pathophysiology is in the trabecular meshwork, we need to perform trabeculoplasty. This is also indicated in the case of medical management failure. Also, we initiate with LASIK trabeculoplasty, and if it does not help, we can attempt trabeculectomy, the same way that we initiated the prophylactic procedure in the acute angle closure glaucoma with laser iridotomy, and if it doesn't work, we proceed with the surgical iridectomy. Now, what are the second line management options for open angle glaucoma? Again, we have our carbonic anhydrase inhibitor, beta blockers, or muscarinic agonists such as betoxolor and pilocarpine. So as you can see, the major difference is, first and foremost, we do not use prostaglandins necessarily in acute angle closure glaucoma, but they are the first line in the open glaucoma. Second is mainly IV mannitol is solely used in the course of acute angle closure glaucoma. And third is the choice of surgery, which is trabeculoplasty in the open angle glaucoma versus iridotomy in the angle closure glaucoma. One last question. What was the gold standard for the diagnosis of acute angle closure glaucoma? While the first test was Schiot's tonometry, the gold standard is gonioscopy. Do we have cupping or visual field defects in acute angle closure glaucoma? No, but the exception is if we have acute on chronic. However, we may risk the sudden visual loss because of the pressure on the retina. And this finishes our discussion of glaucoma.